Welcome back. In the next stage of our exploration of healthcare in the United States, we're going to look at the different levels of care across the healthcare system. And this is going to include hospitals, outpatient settings, long-term care settings, everywhere where an individual in the United States might receive some aspect of healthcare. It is as complicated as the previous two topics we looked at, again, because it's a web, it's a mismatch, and it's no wonder the clients that we work with, as well as us sometimes, can become very confused about what we owe, what's covered, what's not covered, what level of care, all of that. So again, as social workers and being informed about this whole system and knowing where to go to get the information and the resources to help our clients, we can be so beneficial to them. And again, just like the other, we have the complex, the web of different levels of acute care services that still fall under the Centers for Medicare and Medicaid Services, Social Security Administration, Veterans Administration, Indian Health Board, all of those. But now we're going to actually go down into looking at the different levels of healthcare based on medical criteria that an individual potentially needs. So first of all, we've got emergency services, we have acute care, we have long-term acute care, we have skilled nursing facility that's usually referred to as SNF or subacute, we have outpatient options, and then we have physician services. So I'm going to take a moment and break each of these down for you and then try to provide you a little bit about in terms of how the financial coverage happens. Again, fairly complex system, but I'm going to try to give you an overview of each one of these. So first of all, we do have the emergency medical services, and emergency medical services specifically means services used to respond to an individual's perceived need for immediate medical care to prevent death or aggravation of physiological or psychological illness or injury. This comes from the Health and Safety Code here in Texas. Most states mimic it, so it's the same definition. So for a situation to be considered emergency medical services, there has to be an immediate danger to life, loss of life, loss of some vital organ, loss of limb, something like that. So emergency medical services have some very clear criteria that have to be met to fall under this. And remember, if we go back to what we talked about in the last presentation, emergency medical services are the one services in the United States that everybody is, you could say, entitled to. Everybody is entitled to receive stabilization in an emergency situation, regardless of ability to pay. That is the only service that is available to anybody in the United States, but it is there. So the definition of that and what qualifies for an emergency is really important in understanding that, because if you show up in an emergency room and you don't have an immediate medical need that could result in your death or whatever, you could actually be held responsible for the financial aspect of it, even if you are not able to pay for it. So the bottom line is, in an emergency room, in an emergency department, they cannot ask you for your payer source before you've been screened by a physician, and they cannot deny you emergency services as defined by the Health and Safety Code, because you have an inability to pay for it. So that's important to understand for the emergency services. What we have seen, and I'm sure what you have heard in the news, is so many times individuals who do not have access to a primary care physician, do not have access to healthcare insurance, do not have access to any type of community or preventive care, they will come to the emergency room to get vaccinations for their children, or to get basic medical illnesses covered because they have no other place to get that, and they cannot be denied services in an emergency department. So that's part of the controversy in terms of this. And there's been some things that have evolved over the years that we'll talk a little bit about that try to offset some of the cost that happens in the emergency room. It was in 1986 when the federal law was enacted that requires emergency departments to stabilize and treat anyone entering their doors, regardless of their ability to pay. And it's the Emergency Medical Treatment and Labor Act. Like I did before, I'll put up a resource page that's going to have the different web links for these this information that I'm sharing today. Hospitals are required to provide that stabilizing treatment. So if the hospital is unable to stabilize the patient within its capability and its services, it can request an appropriate transfer. We're going to talk a little bit about what that request looks like. But if you have a situation that needs to be served by a trauma 1 hospital or a hospital that has the specialty physicians that are required for trauma level, and you're taken to a hospital that doesn't have that, they can request a transfer. And most hospitals typically will have transfer agreements with the other facilities. So like if you're in a rural area and the hospital is not trauma certified, and when hospitals are trauma certified, that means they actually have to have access to like a neurosurgeon 24 hours a day. They have to have access to highly specialized physicians and highly specialized equipment. Rural areas often don't have that, so they're not going to receive trauma level certification. Individuals who come into those hospitals and require that level of service, they generally will have some form of agreement to have transfer agreements with larger trauma centers, and those are enacted ahead of time. It's kind of a MOU, memorandum of understanding of how that works. However, there's still processes that have to go through before a patient can be transferred from one hospital to another, even if it's an emergency situation. This law that was enacted in 1986 also enacted what's called the anti-dumping law. And what would happen oftentimes is when individuals would show up into a hospital and it was determined they had no payer source, hospitals would load them into an ambulance and send them off to another hospital, and that's called dumping. In the state of Texas, there's actually a process. I know this process well. I did it many, many times, but it's called a memorandum of transfer, and there's a form that has to be secured and completed before transferring a patient to another hospital. And what this means is there has to be a physician acceptance at the other hospital, and there has to be administrative acceptance at the other hospital. So when I was working for the Inpatient Rehabilitation Center in Denison, there were times when I needed to transfer a patient back to a hospital. They were in rehab, they had some medical complication, and maybe they needed to go back to the hospital they came from, or sometimes I needed to transfer them to the VA hospital, the Veterans Administration Hospital. And I would have to begin this MOT process. So I have to get a physician to accept, and oftentimes that requires my physician to talk to that physician. Then I get the name of that physician who was accepted, the time they accepted. This has to go on the form, the name of the physician, the date, the time that they accepted the patient. Then I have to get administrative acceptance, and this is usually from the bed control nurse, because you have to think about it. You can't just send a patient to a hospital when they may not have a bed available. Maybe they're full. Physicians are the world's worst for saying, absolutely, send them, bring them on. They're my patient, send them back here. But you have to have that administrative acceptance also to do. And administratively, it's the bed control nurse, and then they also look at payer sources at this point in time. So both of those have to be filled out on that memorandum of transfer. If, in fact, a patient shows up at a hospital that's been discharged from another hospital and the memorandum of transfer is not completed and not in place, there can be up to a $25,000 fine for that. So, usually if it happens because somebody maybe didn't know what they were doing. There was one point in time I was on vacation, again, when I worked at the rehabilitation center. I was the only social worker there. I was on vacation. Our medical director needed to send a patient back to Baylor. The patient came from Baylor. They developed an infection. They needed to go back to Baylor. And the charge nurse did not know about memorandums of transfers. They had no idea. So the doctor said, sure, send the patient on. So they load the patient up in the family car and send him back down there. And that resulted in our CEO receiving a call from their CEO and said, what's up with this? Why is this patient showed up here and we don't have a memorandum of transfer? And again, you don't want a patient to show up and there not be a bed. There's been times when I've stayed all night at the rehabilitation facility waiting to get that administrative approval. Once a bed's open, we can accept this patient, but do not send them till we have a bed that's open. So then it's a wait and see situation. So this has to happen even if you're in the emergency room. Oftentimes it happens quicker because you're going from emergency room to emergency room and not necessarily to an inpatient bed. But this has to happen. This memorandum of transfer has to happen. Most states have something like this in place because this is a federal law, but this is how it works in Texas. Those memorandum of transfer forms then are collected by the hospital, and they actually have to be submitted into CMS as an accounting procedure. So the anti-dumping law came into effect in 1986 when the law came into effect that said hospitals had to provide emergency services for patients no matter whether they can pay or not. Some of the most recent statistics, according to CDC in 2018, there were 130 million emergency room visits in the United States. That's 40 visits per every 100 persons. In 2017, 91% of the Americans were insured, but many of those had high deductibles. We know now that there's a higher rate of uninsured patients. I did not find that number, but I will try to get that. The thing is a trip to the emergency room on average is 12 times higher than being treated in a physician's office. It just costs so much more to operate in an emergency room. So if you're going to the emergency room because you have a sore throat or you have a cough, you have an upper respiratory infection, the cost is astronomical compared to being able to go to your doctor's office to be seen to get the treated. Of course, now, as we're coming out of the pandemic, there's been a great big push for telehealth services. And this is something really good. I know at A&M Commerce now through our insurance, we can actually access a doctor. They don't have to be our primary care physician. And if we have an upper respiratory infection, if we just have something going on, we can do a telehealth and we can get prescriptions that we need without having to go through and try to get an appointment and with our physician or going to the ER or urgent care. So there's mechanisms now that are coming into place to try to reduce the cost of services in an emergency room that don't need to be there. And when individuals go to emergency rooms, it's not only hugely expensive, but it also backs up the emergency room. So those who are in real emergent needs because of accidents, acute illness, heart attacks, strokes, whatever, may have to wait longer. So this is an ongoing battle in the United States within our healthcare system, is how to handle the emergency room visits so that they're there for the individuals who actually need them, and we're not escalating cost or tying up emergency rooms with situations that don't require the emergency care. And one answer to that became what we call urgent care or walk-in clinics that we have now. So in urgent care, around the 1990s, if you'll see in 1986, that's when emergency services had to be provided, the anti-dumping law went into place. So then in the 1990s, things start happening where individuals are now seeking more and more treatment in the emergency departments because maybe they don't have access to their primary care doctors on nights or weekends. So that started becoming an issue. So what happened is these urgent care centers started evolving. So they're an ambulatory care center. They're a little like a doctor's office, not like an emergency room. They may have a little bit more than a doctor's office does because oftentimes they can do x-rays, they can draw some blood work, they can get some, they may have some internal labs to be able to get some labs fairly quickly. They don't keep medical histories like your doctor does, but now a lot of urgent cares have been established by hospitals and they'll share medical records. So the urgent care doctor may be able to pull up your medical record from your primary care physician if they're all connected within the same system and have that information. And they don't have the real sophisticated medical equipment and the staff expertise to handle those life-threatening conditions. So it's not for emergency services, but it's for urgent care. It's that weekend when you start running that 105 fever or 103 fever and you just feel like crap, and you don't want to wait to try to get a doctor's appointment, but you're really not for the emergency room. So the urgent cares tend to be open in hours that are opposite of when physician offices are open, or when ERs are seen as becoming full. Urgent care centers will try to be open during those hours so that they can catch some of those, and individuals don't end up paying those exorbitant costs tying up emergency services, but don't have to wait to get an appointment with their primary care physician. The coverage for this is typically the same as if you're in a physician's office. So if you have employer-based insurance, it will cover it. Medicare is going to cover it like a physician's office. Some Medicaid programs will cover it for adults and for children. Or you can pay out of pocket, and it's a lot less expensive than going to the emergency room. The walk-in clinics have emerged, and they've actually become a little bit more prominent in the last several years, especially with things like the flu shot. But the walk-in clinics are similar to urgent cares, but they usually have nurse practitioners instead of doctors. And they're often offered within the pharmacies or within the grocery stores or those retail outlets. So they really are there for your flu shot. They've been great for the COVID shot when you talk about the pharmacies like at CVS and the Walgreens. Some type of colds. So those walk-in clinics, that's just what they are. They're just for if you have a slight fever and maybe you need some antibiotics, if you need your flu shot, so that you don't have to, again, try to get into a primary care physician, or you don't have to go all the way into an urgent care. So it's a different level of care, but it's just kind of a catch-all there, and they're fairly convenient. If you're traveling and something happens, you can walk in and you can get treated, and you don't have to be established with them. Several years ago, we were on our way back from Houston, and something was wrong with my eye to the point where I had never had anything hurt so bad in my whole life. And I pulled into one of these walk-in clinics. Actually, I think it was an urgent care. Along the way, I forget where it was. It was between Houston and home. And I'd actually got something in my eye that had cut my cornea. And they gave me some numbing medication for it and said it would kind of heal on its own. But I didn't have to be established with anybody. I didn't have to go to the emergency room. I was able to just do a walk-in. My insurance covered it. I had like a $20 copay. So if you're traveling, if you're out of your area, these walk-in clinics, these urgent care centers are also good to be able to handle some of these minor things and keep you out of the emergency room. So now we're going to talk about inpatient stuff. And the first level of inpatient care that we typically have is acute care hospitalization. So oftentimes if you end up in the emergency room, you may have a situation where you're going to have to be admitted to the hospital. If you're admitted to the hospital, it's going to be for a condition that meets acute care criteria, and it's a medical condition or an injury, usually short term, or maybe you're going into the hospital for a surgery. So there's specific criteria, medical criteria you have to meet to be classified as an acute care hospitalization. And this can become confusing at times because you can be admitted into a hospital but not be an inpatient. You can be in outpatient observation, and this has financial implications. If you have a medical illness or injury, surgery, something like that, that requires that inpatient hospitalization, then the doctor knows what that criteria is. He documents that in your chart, and he writes the order to make you an inpatient. If you come through the ER and you have something that they want to just watch you for 24 or 48 hours, they can put you into a hospital bed, but you may not meet acute care hospitalization requirements, so the doctor writes that you're in outpatient observation. You can be in outpatient observation for 48 hours, and then they either have to discharge you or they have to switch you to inpatient. And so if you don't meet criteria for inpatient, you're going to be discharged. If you're in an outpatient bed, you're responsible for the cost of your medications. You're responsible for copays. There's a different financial responsibility is if you're outpatient versus inpatient, especially if you have Medicare. Medicare pays the first 60 days of an acute care hospitalization inpatient stay at 100% after you've met your deductible. If you're in an outpatient bed, it goes to Medicare Part B, and there's a co-insurance there. So this can become confusing to individuals when they're admitted to a hospital, but they're not admitted as an inpatient, and they end up with different financial responsibility than if they are an inpatient. Technicality, but it does require a physician's order to write you to be inpatient or outpatient observation. There are utilization nurses that do nothing but go through charts on the floors, and they look at the charts, they look at the diagnosis, they look at the treatments to see if this patient will meet and qualify for inpatient services or continued inpatient services, because it behooves the hospital to either get you out of that bed and get you back home, or get you converted to inpatient, or to make sure you still meet inpatient criteria. Otherwise, it will have financial implications for the hospital in terms of reimbursement when they bill insurance or when they bill Medicare. So acute care hospitalization can be inpatient or outpatient within a hospital setting. So once you're not qualifying for acute care hospitalization, inpatient or outpatient, you're going to probably end up in some type of post-acute services. There's inpatient post-acute services, means where you actually go to a facility and you stay there, or there's outpatient post-acute services or ambulatory care type services. So I'm going to talk about first LTACs, which are long-term care acute hospital settings, IRFs, which are inpatient rehabilitation facility settings, and SNFs, which are skilled nursing facility settings. Now, these not only reference the physical setting for the care that's being provided, but it also references the billing options and the financial reimbursement based on the different criteria for these. Okay, so let's talk about LTACs first, long-term care, acute care. So what happens is, as we saw with an acute care hospital admission, it's generally for short term. You're generally not going to be there weeks upon weeks upon weeks. But occasionally there is medical criteria and you have a complex medical situation that has multi-organ involvement, that you need longer acute care hospitalization than what's feasible under acute care. We go back to one of those very first presentations I did, I talked about the diagnostic related groups, DRGs. So again, if you have pneumonia and you're admitted into an acute care hospital inpatient bed, you may have, or the hospital may have 9.1 days, a DRG. Basically, they'll receive reimbursement for 9.1 days of providing you care. And after that, they're not going to receive any reimbursement for your care, because that's the average length of stay for somebody with a diagnosis of pneumonia. But let's say while you were in there and you had pneumonia, you developed kidney failure and you had a heart attack and you became septic, so you have infection throughout your blood. So you have all these complications and you need longer stay. What was developed was long-term acute care facilities, or LTACs, that are DRG exempt. These are paid fee for service. So in an LTAC, a hospital that has beds certified as LTACs can keep somebody in an acute care status for a longer period of time, not be held to that DRG, and get higher levels of reimbursement because it's more expensive to treat these individuals on a long-term basis. So they must meet acute inpatient criteria, okay? And they have to have one of the criteria of having persistent multi-organ failure, multi-organ involvement, some type of complex medical needs. So there's some other diagnostic criteria that they have to meet to be in LTACs. I presented two examples, and Vincor or Kindred, if you've heard of them, typically they're an LTAC and they take individuals who are on ventilators because it can take a long time to get somebody weaned from a ventilator. And this is something that has exploded obviously during COVID and the need to be on ventilators. But some of these individuals who even had COVID have to be on ventilators for weeks on end. Well, a hospital can't keep somebody in an acute patient bed that's for short term for weeks and weeks on end. They need to go to the appropriate level of care, which would be like an LTAC. So employer-based insurance plans typically cover the cost for LTAC under the same conditions as short-term acute services. Medicaid does not cover the cost of LTAC at all. Medicare does cover the cost, just like if you were in an acute care inpatient bed, which means those first 60 days are at 100%. And then there is an additional days 61 through 90 that's paid at a coinsurance rate. So if you're Medicare and you become ill, per episode of illness, you have 90 days of acute care inpatient covered. Okay, 90 days, 60 days 100%, 30 days at a coinsurance rate. If you have to be in a hospital longer than that, you have an additional 60 days of lifetime reserve days. If you use your lifetime reserve days, they are never renewed. They're gone forever. So if you use those and have to get into those, you'll never have those. But your acute care days, once you have a 60-day break in the spell of illness, your acute care days renew. And a 60-day break in the spell of illness means you're out of a hospital setting for 60 days. Then your acute care days renew, that 1 through 60 and 61 through 90. Your lifetime reserve never renew. Individuals who have Medicare and have to go into LTACs typically will use their lifetime reserve days, and they could eventually be out of Medicare days, period, if they don't get that 60-day break in the spell of illness. So that runs into some financial complications for individuals who have Medicare. IRFs, or licensed inpatient rehab facilities, they're also licensed at an acute care level. So there's specific criteria, again, that has to be met. Primarily, you have to have a condition that requires a doctor to see you daily. You have to require nursing care 24 hours a day, and you have to require 2 out of the 3 disciplines for physical, occupational, or speech therapy. And you have to be able to withstand 3 hours of therapy a day. Now, in the IRFs, or the inpatient rehab facilities, oftentimes these are associated with hospitals. They can be freestanding and only be that, just the inpatient rehab facility. They still have to meet this criteria. They also they're DRG exempt, so they're paid at a different rate, meaning if you went in there with your diagnosis of pneumonia, the 9.1 days are gone, they get paid differently, so they're DRG exempt. But they have to meet that 75-25 rule, and they've gone back and forth. It's been 60-40 at some points in time. But what this rule is it says that 75% of their admissions have to come from specific diagnostic related groups, neurological conditions, trauma, strokes, brain injuries. There's some other specified conditions in there. 75% of the individuals coming into an IRF must meet this criteria. Only 25% can be a debilitated condition. What happens is if you're elderly or if you're older and you have knee replacements, okay, you have a hip replacement. Some of these orthopedic conditions, when they go into a rehab setting, they're classified as debility. They don't meet the 75, so they come in under that 25%. So you're 55 years old. You have 2 knee replacements, bilateral knee replacement, single. I think bilateral do meet it. But let's say you have a knee replacement and your doctor wants you to go to an inpatient rehab to recover. The rehabs in your area have already taken their 25% ratio for that month. They're not going to have a bed available for you, even though you have insurance that will pay for it. This becomes very confusing to patients. Why can't I go? Why, that doesn't make sense. It does in the bigger scheme of things because they have to meet this ratio, and your diagnosis doesn't meet that ratio. So the doctor then has to find a different place for you to go if you need inpatient rehabilitation versus doing some form of outpatient or home health therapy. But again, acute care level, DRG exempt, must have specific criteria to be admitted to an inpatient rehab facility. Down from the inpatient rehab facility is what's called SNFs, skilled nursing facilities. You hear them called that. This is sometimes you may hear them called subacute, SNF or subacute. It's the same level of care, okay? Whether it's called SNF or subacute, there's not different reimbursement categories for that. The SNF facilities typically are located within a nursing home. And what that means is a nursing home has taken one wing, the beds in that wing, and they've certified those beds as SNF. If they're SNF beds, Medicare covers a portion of the stay because that individual is seen as only being temporary, not living there in a long-term care situation, okay? So SNF is actually a level of care and not really talking about the physical structure. Some hospitals have taken a floor of their hospital and created a SNF unit. So an individual could have surgery on the 3rd floor and then be discharged to the SNF unit on the 4th floor. It's a separate unit. Instead of somebody having to go to a nursing home and doing the SNF stay and rehab, they can go within the hospital. So there's different ways to get to this level of care. What I'll say is, I'm going to guess probably 90 to 95% of SNF beds are located in a nursing home. That's always a negative for somebody who needs to go to a SNF because they don't want to go to a nursing home. But not all hospitals have SNF beds, and I think they've tried to have some freestanding SNF units, but they really don't have them. They have to be connected to something else for financial reasons. So again, it may be referred to as subacute, but there's no different payment. And when I say that, if you look at Medicare, the categories of Medicare, Medicare pays for acute care, Medicare pays for SNF care, Medicare pays for outpatient, and Medicare pays for home health. There's only 4 pots of money under Medicare to draw from for all these different levels of care, okay? Insurances, employer insurances, tend to follow Medicare's pattern. So your insurance could potentially call it subacute care, but it really is SNF care. There's not a separate category for it. And that can become confusing sometimes too. Most employer-based insurances have a SNF benefit. Medicare covers the first 100 days with 20 days covered at 100%, and then the remaining 80 days at a co-insurance rate. Medicaid does not cover SNF level of care. Medicaid does not pay for that. Generally, to be admitted in for SNF level of care, you don't have the complex medical condition, but you're going to need some type of nursing service. It could be long-term wound care. It could be stabilization for acute diabetes, some renal failure, and you're also going to need some form of therapy, physical, occupational, speech therapy, something like that. But either you can't stand the level of the 3 hours of therapy a day required to be in an inpatient rehab facility, or you have one of those conditions that don't meet the criteria for that 75% admission rate. So you have inpatient rehab facility, you have SNF level of care, you have acute care in the hospital setting. So these are typically your inpatient where the person is staying there. And then you have these different pots of money that get drawn from and different qualifications and different deductibles, whether it's acute care, inpatient, acute care, outpatient observation, inpatient rehabilitation, LTAC, or SNF. You also have post-acute residential services. And these are like long-term brain injury services or spinal cord injury. They are not acute care level, but individuals will go there and stay. Pate Institute is one of the most well-known nationally ones, and it's located in Dallas. They actually have a residential service located in Anna, Texas, called Brindley Creek Ranch. Craig Hospital is a nationally known hospital for spinal cord injury out of Colorado. So these are long-term individuals who need long-term brain injury recovery or spinal cord injury recovery can go to these places. They're residential. They're not covered by Medicare or by Medicaid. They're generally funded through employer-sponsored insurances, workmen's compensations, or Department of Aging and Disability Services. And we'll talk about DADS a little bit towards the end of this. So if you have the Medicare, the Medicaid, it's not going to cover this. But most of these are going to come from employer-sponsored insurances, workman's comp, or DADS. If you think about employer-sponsored insurances, if the individuals had a brain injury or a spinal cord injury and they are on their employer-sponsored insurance but they're not working anymore, then you have to consider, do they need COBRA insurance? Are they going to have to pay their premiums? When will they have to do that? When will they be out of paid time? So you have to work through those situations oftentimes with your clients. Years ago, when I was working in the acute hospital before I went to the rehab setting, there was a young man in there. He worked for the city of Sherman. He had a self-inflicted gunshot wound to the head. He was alive, but he was comatose. You couldn't talk with him or anything like that. And as I was working on his case, because I was needing to get him to a brain injury situation out of the hospital, I got to thinking and working through some of that and thinking, he's got his own insurance, but he's not working. So how is his premiums being paid? And at that point in time, it was before the Affordable Care Act. So you only had 45 days to pay your COBRA, to accept COBRA and pay it after notification. He lived independently. He lived alone. I tracked down, got in touch with his parents. His parents got in touch with the city. We were able to intercept that like within 30 days. We lacked just a few days. Our hospital would pay COBRA payments for an individual who was in that situation because it was less costly for us to pay their COBRA insurance than it was to keep them there uninsured. And I was able to get that one turned around quickly because his parents were very responsive and very helpful. So we were able to keep him insured, which helped me get him to a brain injury rehabilitation situation because he had insurance through the COBRA that we were paying at the hospital. So some of those things get a little bit creative, but again, understanding the complex systems and thinking about that and how those things work, you can really benefit your clients. Then, of course, we have ambulatory care, and these are medical services that are performed on an outpatient basis without admission to a hospital or other facility. This can be preventive, non-emergent sick treatments like you may get. We talked about the urgent cares. We talked about in the walk-in clinics. We talked about the doctor's offices. So these are things that you can get done. They're non-emergent, ambulatory care. You walk in, you walk out, you don't stay there. Models for insurance coverage on this, if you have employer-sponsored insurance, or even if you have some of the Medicare Advantage plans, they could be an HMO. And an HMO means that you're restricted and you can only go to providers that are within that health maintenance organization. If you go outside of that health maintenance organization, your services are not going to be covered. It could be PCP, which requires a referral from a primary care physician to see specialty physicians, to see a cardiologist or to see an orthopedist or something like that. Your PCP may have to make that referral. Or it could be a point of service. And the point of service means that you're able to see anybody who participates in that network, in your network, Blue Cross Blue Shield or whatever. So even to see physicians and ambulatory care, you have to have a good understanding of what your insurance is going to cover. If you have Medicare, then you need to make sure that the physicians that you're seeing or the places that you're seeing are accepting Medicare assignment. If you have Medicaid and you're an adult It doesn't pay for all of these services, so you need to know what services are going to be covered. If you have Medicaid and you're a child and your child has Medicaid, it's going to pay for more services on an ambulatory care basis than it does for adults. These type of services also include things like outpatient services at a hospital setting, which could include laboratory services, imaging services, infusion services. Some hospitals have infusion services set up where if you need IV antibiotics on a daily basis for a period of time, you can come in and they'll hang your IV antibiotics, you take your IV antibiotics, and then you leave. If you have a protracted type of infection that requires that. Chemotherapy could be done on an outpatient ambulatory type basis. There can be outpatient services that would include physical occupational speech therapy, wound care services. All of those can be considered outpatient. Even through a hospital, they can be ambulatory care or outpatient services. If it's the outpatient services, again, it's covered under Medicare Part B, not Medicare Part A. When you get your Medicare, when your clients get your Medicare, they have to opt into Part B. So it's not an automatic that they get it. They have to opt into it, and then they have to pay a premium every month for Part B. If they only have Part A, then they're not going to have a way to pay physicians. Part A pays all of your inpatient stuff, and it pays your home health. Part B pays your physicians, pays your outpatient, pays your medical equipment. So individuals really need Part A and Part B and Part D, which is prescription coverage. But oftentimes they don't want to do Part B because it costs a premium. Depending upon their financial situation, there's 3 types of Medicaid that can help that. There's SLMB, QMB, and then there's the MQMB. SLMB is a supplemental, and what it does is it actually comes in and it pays that medical premium. So if the Part B premium, I forget what it is, it may be close to $90 a month now. Say the Part B premium is $90 a month. Financially, if they qualify, they can apply for SLMB, and it will pay the $90 a month, and they won't have to pay that. If they qualify for QMB, Qualified Medical Beneficiary, they have their Medicare, and then QMB will pay that Part B premium, and then it will also pay co-insurance because Part B has a co-insurance that the individual has to pay. If they qualify for MQMB, then that's the highest level of Medicaid for aged and disabled. It pays long-term care in a nursing home. It pays for some provider services if you're at home. It pays the Part B and it pays the co-insurance. So if you have somebody who has Medicare, there can be some additional assistance for them for their Part B aspect of it, but they really need both. If you don't purchase Part B when you're eligible for Medicare and you want to purchase it later, you're going to be penalized and your premium's going to go up. And at some point in time, it's going to be where you can't afford it at all. So if you're working with clients in this age range, they need to understand the ramifications of not accepting the Part A or the Part B. If they go with Medicare C, which is the Medicare Advantage plans, then there's some different benefits for doing that, and they can make those choices. So they won't have Medicare fee-for-service, which is traditional Medicare. They'll have an Advantage plan, and they may not need the Part B, but then they're still going to end up paying something. So you really have to put a pencil to this and help individuals try to figure out what their best options are going to be based on their medical needs, okay, their current health, and their financial situation. And then you have the ambulatory surgical centers. And the ambulatory surgical centers, of course, are where you go in for a procedure and then you go home the same day. Some rare cases you may stay overnight, but they're not acute care hospitals. They're not emergency based. This is where you go for your colostomies. Not your colostomies, but your... but this is where you go for some of your... just those day procedures where you may have something done and you go right home and you don't have to be there for overnight. So ambulatory surgery centers are less expensive than going to an acute care hospital. So that's where you would have some of those done. Then you have your specialty clinics or centers, like for your hemodialysis. Individuals who need hemodialysis go to a center during the day, hook up to the machine, have their dialysis. Many individuals still work, so they do it around their work hours. It's specialty. That's all it has. I will say, from a federal standpoint, from a Medicare standpoint, every dialysis unit in the United States is required to have social workers, required to have a graduate level, master's level social workers. So all dialysis units have social workers. Peritoneal dialysis, that's done at home. So that's a home-based dialysis that you don't actually go into the hemodialysis. You have a unit at home and you do peritoneal dialysis. Infusion, IV antibiotics, I mentioned that a little bit earlier. There's some places, some hospital settings that have units where you can just go and get your antibiotics if you're going to have them long term. Wound care is typically ambulatory specialty clinics. You can go into the hyperbaric chambers. And then some rehabilitation services, again, for the outpatient type services. Some of them have day programs even that individuals can go to. So those are considered ambulatory care and would be paid under what's considered outpatient services, Medicare Part B, or with your employer, it would be some type of outpatient services. Then, of course, we have home health services. And for home health services, the individual requires some type of part-time or intermittent skilled nursing care, may require some home therapies where a physical, occupational, or speech therapist comes to the house and works with the individuals. Medical social workers are available through home health services. Interesting enough, a medical social worker is one of the highest reimbursed profession under Medicare in home health. But most of the time we just go out and do assessments. We don't do ongoing treatment. Part-time intermittent home health aides, and it has to be for personal care. So if you're on home health services under Medicare or employer-sponsored coverage, then your home health aide can do things related to your personal body. They can help you bathe. They can help you eat. They can change sheets on your bed because that is for your personal body, but they can't do any other housework. They're not reimbursed for that. It can also include infusion therapy in the house. So sometimes that will also include the drugs under the infusion therapy, but now that there's Medicare Part D in place, oftentimes that the drugs are covered under that, and then the infusion therapy is through home health services, covers the equipment, the IV bags, the nursing administration, that type of thing. You have to be under a doctor's care, and the doctor has to implement the plan of care, and you have to be homebound, and homebound means you have to have difficulty getting out of the home. It can't be something easy, and there has to be some limitations for really you just get out of the home in terms to go to the doctor's office. You can go to church, but anything beyond that, you may not be considered homebound. And for you to be eligible for home health services, you have to have that homebound qualification. Again, for funding options to cover variety of healthcare services, we have our employer-based insurance, or we can purchase private health insurance. These are third-party insurances. Depending upon what plan is offered under your employer, depends on what services are covered. So I may have Blue Cross Blue Shield with my employer, and my husband may work for a different employer and have Blue Cross Blue Shield, and we can have very different plans, okay? Blue Cross Blue Shield is not a one all-time plan. There are multiple plans under Blue Cross Blue Shield that they in turn sell to employers, and depending on the size of the employer, depending upon what services they want to honor and put in there, they can pick and choose what they want their plan to cover, what their deductibles are, what their out-of-pocket is, what their co-pays are. So Blue Cross Blue Shield has a variety of plans. Aetna has a variety of plans. United Healthcare has a variety of plans. And just because you have not United Healthcare doesn't mean you're going to have the same benefits and coverage that your neighbor has who works at a different company. So employer-based insurances vary based on the employer. You have Medicare. And again, we talked earlier on previous presentations, Medicare is for aged and disabled. If you've reached age 65 and you've met the 41 quarters for work under Social Security Administration, you're eligible for Medicare. You're eligible for Medicare Part A, for Medicare Part B, and for Medicare Part D. You purchase Medicare Part B and you purchase Medicare Part D. Medicare C is the Advantage. What is the Advantage programs, which means you can opt out of traditional fee-for-service Medicare and choose one of the Advantage programs. What I know about those is you really do have to put a pencil to it, because sometimes it will be more expensive for out-of-pocket services, or there may be services that Medicare fee-for-service, which is traditional Medicare, offers that the Advantage program does not. Some of those Advantage programs are also HMOs, which means all of a sudden you're restricted to who you can use. So again, it's a trade-off you have to determine. If you're under the age of 65, you can be eligible for Medicare if you qualify for Social Security Disability Income, SSDI. That means you have to have your work quarters and you have to be disabled for 30 months. When you file for disability under the age of 65, you have to be disabled for 6 months prior to being eligible to receive your first disability check. If you are approved for disability by Social Security Administration, the 7th month you receive your first disability check. You then have to receive 24 payments to be eligible for Medicare. So an individual who becomes disabled under the age of 65 is not going to be eligible for Medicare typically for 30 months. That's going to be the criteria before they can get it, unless it's end-stage renal disease, and then they'll be eligible within 3 months, or if it's ALS, they'll be eligible quicker. End-stage renal disease, that was approved years and years ago, and to waive the 30 months and have them eligible within 3 months. And it was done because a person who was doing dialysis, peritoneal dialysis, went to the floor of the Congress and did an exchange in front of all the legislatures. Now that's advocating right there. That's actually doing some demonstration to be able to get that benefit. Medicaid. Medicaid varies by state as to what it will cover. It varies as to type of Medicaid. If you qualify for disability under the age of 65, if you become disabled and you don't have the financial means to earn Social Security disability income, you haven't had enough quarters, something like that, you can get SSI, Supplemental Security Income. And it's an income, so you get a monthly check, plus you get Medicaid with it. So SSI Medicaid for adults pays more options than if you're on TANF Medicaid, or if you're on another type of Medicaid. If you're over the age of 65, you can get SSI Medicaid as a supplement to your Medicare if your disability check is under the required amount. So again, there's a financial qualification to get SSI Medicaid, which is through the Social Security Administration. If your child is disabled and based on financial criteria for the family, they can receive SSI. SSI, again, gives you a monthly check and then the Medicaid along with it. What we talked about for those 65 and older who have Medicare, you also have your Medicaid supplements, which is your SLMB, your QMB, and your MQMB. If you are an adult with Medicaid, it is not going to pay for rehabilitation services. It's not going to pay for a lot of those specialized services. It's going to pay some for acute hospitalizations. It's going to pay some for prescriptions. It's going to pay some for some outpatient services, but it will not pay for any type of rehabilitation services for an adult. Typically, that's going to have to come under the Department of Aging and Disability Services, which used to be Texas Rehab Commission. And then you also have the workman's compensation. So workman's compensation is also a form of payment to cover medical care for somebody who has been injured on the job. You could be working with clients who have workman's compensation. Department of Aging and Disability Services, again, the goal is to get the person back to work. So if that individual has become injured, if ill, they don't have medical coverage to receive rehabilitation services or to receive prosthetics that they might need or to receive something that would allow them to go back to work, then they can apply for Department of Aging and Disability Services to get some funding to cover those expenses to be able to go back to work. Again, this was the Texas Rehabilitation Commission years ago. It's all been rolled into one. So these are some different forms, different ways of paying for medical coverage in the United States. And as I've said all along, it's very complicated. It's a web of services. It's mismatched. It is just confusing. But if you can wrap your mind around all of this, you have such human capital and you can be such a source to your employer and to your clients so that everybody gets maximum services, so that we can maintain costs, keep the cost low as possible, and really get some policies going so that we can, what we're going to learn towards the end of this semester is to create that culture of health so that we can reduce our healthcare costs. We can reduce the human suffering that we have because of medical issues that we have. But between the oversight, the administrative structure where you have your Social Security Administration, Centers for Medicare and Medicaid Services, your tribal services, and your Veterans Administration. Under that, of course, you've got your different levels of care. Then you've got your different fundings for it. All of this puts together the pieces to put together the puzzle and to paint, again, this very abstract picture of healthcare in the United States. We also have hospice services. Hospice services, if you think about home health services, hospice services are essentially going to meet home health services, but the physician certification for that individual must state that they have a condition that will likely result in death within 6 months. So the services are typically the same, except you're not going to see the rehabilitation services because the goal is not to rehabilitate that person, but the goal is for palliative type care, pain control, a lot of psychosocial issue. All hospice services have social workers. The individual doesn't necessarily have to be homebound to be on hospice services, but they usually are. Hospice is covered under Medicare Part A. If an individual is on hospice services, then they provide the medical equipment, the medications, everything goes under hospice services. And so that it can actually be a little bit more financially lenient than if it's home health or some of the other services that are out there. But this is for individuals who are in the end stages of their life. And I don't want to forget dental services. Dental services pretty much are only covered through employer-based insurances. Or if you're a child, Medicaid will cover dental services. Other than that, dental services are out of pocket. They're just not covered. Medicare does not cover dental services, especially they do not cover dentures or any type of oral surgery. Some of the Medicare Advantage plans will have coverage for dental services in there, but it's going to be fairly limited. And this is really interesting to me, given that there's a lot of link between heart disease and periodontitis, can't hardly say that, and infections in the tooth infections can result in brain injuries. So there's some connections in there, but virtually, if you don't get it through your employer, there's really nothing that covers for dental services if you're an adult. It's out of pocket. You just don't have coverage for it. The VA they have their own dental services and their own dental uses, so you could potentially qualify there. And then the other thing is you can actually get clients on the list for dental schools. If there's dental schools in your area, then they accept clients who don't have insurance coverage. And I've been able to get some clients into some of the dental schools in the area if they needed some pretty significant dental work done. And then finally, long-term care. And long-term care is really when an individual needs a residential setting that requires some form of nursing care services on a daily basis. This is nursing home, what we call nursing homes, and the long-term care facilities. Again, Medicare only pays if you're in one of those qualified SNF beds, if you're in a nursing home, and that's only temporary. It does not pay for the long-term care. This is seen as an individual's home. So when somebody's in a long-term care setting for long-term, it's recognized as being their home. So Medicare, which only pays for healthcare services, will not cover it. Medicaid only covers it if they qualify for the MQMB level, which is the long-term nursing home care Medicaid. In the state of Texas, you can look at spousal impoverishment and the Medicaid waiver programs. There are financial qualifications to qualify for Medicaid for the MQMB, and this is where you'll hear individuals talk about how they can't have any resources, they have to get rid of everything. In the state of Texas, you can own your own home, and it's exempt for 1 year. From resources. You don't have to do anything with it for that first year. It's not counted as your resources. They look at resources as savings, stocks, bonds, cash value for life insurance, if you can turn your life insurance for cash value. Anything over $2,000 is considered resources, and it will negate you qualifying for long-term nursing care. And again, your home is exempt for 1 year. Previously, the home was exempt in Texas, and you never had to claim your home. And this is for a person who's single, not somebody who's married, but for a person who's single. You didn't have to claim your home ever. And then the pressure got put on when not Governor Abbott, the governor before him, we were going to lose our federal funds for highways if we did not institute a Medicaid Recovery Act. We were one of 2 states holding out in the United States that did not have a Medicaid Recovery Act. And what that means is if you are single and you own a home and you go into the nursing home, you can qualify for MQMB. But what's going to happen is the state will put a lien against your home. And at some point in time when that home is sold, the state will collect back the money that they paid the nursing home. It has been instituted sometimes. Sometimes the home's not worth it and the state doesn't even pursue it. But this did go into effect several years ago. I forget the exact year, but it went into effect several years ago. So all states now have a Medicaid Recovery Act. If you are married and one of the couple, only one goes into the nursing home, the other one stays at home, the home is exempt. It doesn't become a part of the resources. Half of the resources are exempt, and half of those resources up to, $200,000 are exempt. So say my husband goes into the nursing home and I stay at home. Our house is exempt from resources. It is not counted at all. It is mine, and it just stays the same as it is. Say we have $75,000 in savings. So they're going to take, it's a minimum of $50,000 up to $200,000, something like that. So they're going to take that $75,000 and they're going to split it in half, and they're going to say half is his and half is mine. But they'll protect up to $50,000 for me. So they'll actually take $50,000 of that $75,000. They'll award him $25,000 as his half, and we will have to pay the nursing home until that $25,000 goes down to $2,000. Then he will qualify for MQMB. There's a couple of other tricks in there, but just know that it's not straightforward. You don't have to get rid of your resources. If you put everything into a irrevocable trust, so if all of your resources are into an irrevocable living trust, not revocable, irrevocable living trust, and they've been in there for 5 years when you need to go into the nursing home, none of those are counted as resources. So it won't prevent you from qualifying for the long-term care Medicaid, and you won't have to get rid of those resources. What you don't want clients to do is you don't want them to transfer anything. Anything that's transferred 5 years prior to you going into the nursing home will be counted as a resource. So let's say I'm 75 years old and I decided to go ahead and transfer my house out of my name and put it in my daughter's name, and then in 3 years I have to go in the nursing home, and my house was worth $125,000 when I transferred it, I'm now going to be taxed with $125,000 in resources because I transferred that within a 5-year range of going into the nursing home. Therefore, I'm not going to qualify for long-term Medicaid. So this is where it does help to get some advice from, if you don't have a financial planner or who understands long-term Medicaid, you really need somebody that understands long-term care. Not all lawyers do, not all financial planners do, but you can get assistance through the Area Agency on Aging. Every county has an area agency on aging, and there's a certified benefits counselor within every area agency on aging. I was a benefits counselor for many years, and I had that certification through the state of Texas. So that is available to individuals, and they can help you understand all the ins and outs specifically to long-term care and how to protect resources and how to understand what you're going to be financially responsible for.